Now we've thought a bit about activity and what it feels like when you can't do things on your own independently, and then how it feels to have somebody assist you to be independent. What we want to do now is go back to the list of all the different things that can happen to a person when they have a stroke. I'm going to look at those in a bit more detail. So the first thing on our list then was hemiparesis or hemiplegia. This is basically weakness or paralysis to one side of the body. Now, about 80% of stroke survivors will have some sort of motor impairment, some sort of a problem with movement. Commonly you see people who have a weakness to one side. If someone has a stroke in the left side of the brain, it will be the right side of the body that's affected. If it's the right side of the brain, they'll have a weakness to the left side. I've said that it occurs to one side of the body, but some people have more than one stroke, so you might find somebody who's got a weakness on both sides if they've had bilateral strokes. The severity of weakness also varies from person to person, so you might have some people who have complete paralysis to one side, absolutely nothing moves, it's just a dead floppy arm, can't move the leg, they've got no trunk support in the side of the body, just completely useless down one side. Other people just have a slight weakness. Some people will be able to walk around, so maybe the lower half of the body hasn't been affected, but maybe they've just got an arm weakness. Some people just have a weakness to the face and the arm. It could just be the face, the arm and the trunk. It could be the whole lot. So it depends on the person. It depends on the amount of damage to that motor area of the brain. Now, when people have paralysis or weakness, they often also have problems with sensation, and that's because the area of the brain that controls movement is very close. It's next door to the part of your brain that controls sensation as well. This is an arm support. So often if people have a weakness to one side of the body, when they come out of hospital, they're often encouraged to try and support the weight of their arm. So for example, if you've got somebody in a wheelchair who's got absolutely no movement in their arm, you don't want to see the arm hanging down the side of the chair, do you? It's because they might also have sensation problems, so they might be getting the hand caught on the wheel and they might be causing skin damage that can lead to infections and things, so they might be damaging the limb if they're getting it caught. The other thing, and it's to do with this thing called shoulder subluxation. Big fancy word, but what it really is partial dislocation of your shoulder joint. Now you know that in your body you have lots of different joints that allow movement. If we didn't have joints, we'd be rigid, wouldn't we? But we have different types of joints. So your knees are like hinges, they just move in that direction. But because we use our hands and our arms in activity, we need to have lots of movement, don't we, with our arms to do all the things that we need to do with our hands. So this type of joint in your shoulder, it's like a ball and socket joint. Because if it's a hinge, you'd only be able to move it like that, wouldn't you? Or like that. So it's great because it allows lots of movement having that type of joint. And normally, you have all your muscles and your ligaments and tendons, everything is holding your arm in place in the joint there. But when someone has a stroke, if it affects the muscles of that side of their body, all the supporting structures that normally hold this arm in place in the socket there, if they're weaker, the whole weight of their arm hanging down can cause it to subluxate, to dislocate, to come out of the shoulder socket. And this is going to lead to pain to the individual. It's going to make them more uncomfortable. So that's the reason why occupational therapists and physiotherapists are often banging on about supporting the arm. And the easy ways to do it are either you can just have a cushion, you can roll up big towels so you've got something wedged in next to the wheelchair. If you've got a wheelchair that allows you to use a table in front, then obviously you can use that and place the hand in front. This is an arm hand support that you can get from one of the equipment catalogues, so it's a bit spongy like a bean bag, and you just place it under the shoulder and it just supports the hand there. You've got it on a table. Mm-hmm. And the good thing about this as well is it's bright green, so it reminds people that the hands are supposed to be on there. You know, sometimes people have memory problems, or they might forget that they're supposed to be looking after their limb. This bright green thing's there to remind you. Sometimes people have other problems. They have spasticity in the muscles. So, you know, our muscles work in pairs, don't they, to allow movement. So, for example, if I want to bend my arm, this muscle here, my bicep, will contract to let me straighten it. My tricep at the back will contract to let me straighten my arm. Now, for some people after stroke, because of the damage to their brain, their muscles aren't functioning correctly. Things aren't working right. And for some reason, for some people, their muscles, one part of the muscles, one set of the pair, if you like, start to overwork. So the muscles on this side are trying to contract all the time, but there's nothing on the back working to help straighten the arm out. So you see people who start to get tight fingers, tight wrists, tight elbows, and sometimes they get to the point where they're like that and you can't physically move it, you can't do anything about it. So there's a problem there. Obviously, if the nails are going to start digging into the palm of the hand, if it gets to a point where you can't stretch them out and cut the nails, they're going to start getting cuts. So we have these palm protectors that we use. So these palm protectors are just there to stop the nails from digging in, really. But some people, it's got to the point where it's so tight you can't even get that in.
I'm trying to sort of get between just to wash it.
Yeah.
Right.
If somebody has spasticity, if somebody's starting to get those muscles overworking on one side, if you get them to do anything that encourages flexion, bending movement, it'll make it worse. You need to break the pattern. So actually, people used to think, well, they've had a stroke, they've got a problem with that arm, we'll put a squeezy ball in there and we'll try and get them to squeeze it to build the muscles up. Actually, that does the opposite. It increases, because you're working the muscles that are already overworking. If you squeeze something, having something like that there sometimes can increase that pattern. And also, just if someone's positioned in that bent sort of flexed position. So say some people cradle their arms, don't they? And if someone's got an arm, you'll see some residents that will hold the bad arm and look after it, and they'll sit there holding it like that. And if they're in that position all the time, it's a bit like, you know, if you sit cross-legged on the floor for too long and you get up and you're really stiff. If you're always in one position, eventually the muscles shorten and contract and you're stuck in that position. You get stiff. So you want to discourage people from keeping their arm in that position. Try and get them to hold it in a neutral position. So keep it supported, keep it neutral, don't hold your wrists like that, because it's going to, again, you're going to start getting contractures there. But the other thing that I think often staff in care homes don't realise that there are spasticity clinics. So just because people are in a care home doesn't mean that they're not able to access these services. Often it's not easy, but they have a right, just as much as people in their own homes and the community, to be assessed for things like splinting, but for things like Botox as well. Botox was actually developed for people who had Parkinson's and people with stroke and spasticity problems. And what Botox does, it's a toxin that actually paralyses the muscle. So they inject into the muscle that's overworking to try and stop it from being so resistant to let the other muscles have a chance. So people can be referred. You can get the nurse can ask the GP to refer to a spasticity clinic in the hospital, and people can be assessed then by a specialist spasticity consultant, neuro consultant, for whether they're suitable for Botox injections to keep maintaining the hand, the limb basically, to stop them getting to a point where you can't manage them. If it's got to that point, and if someone's been like this for years and years and years, sadly it's very unlikely that Botox is really going to be able to do anything, because if the muscles have already started to shorten so much that they've got a fixed contracture. A contracture is when it's shortened, so the muscles have shortened so much that you can't move somebody. The other thing is, as well as just supporting it, you know, when you're helping people to do things like get dressed, you want to avoid holding the hand and the wrist and pulling the limb. You know, don't want to be pulling, because again, you're putting pressure, aren't you, around the area. Instead, you want to be supporting the arm all the time, holding the weight under the elbow. And when you're moving and handling people as well, you want to be careful that you're not letting the arm hang down.